Hi, this is Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 5 conversations from episode 13, our preview of the upcoming Innovations in NAFLD Care Conference in Barcelona. And from the vault, we have conversation 24.4 from season 3, the last part of our wrap-up episode from the inaugural INCBCN conference last May. It's interesting to review what Jeff Lazarus and Jörn Schattenberg anticipated then as compared to what we discussed in previewing this year's conference. I start this conversation by asking about the role of non-physicians in the program. Jeff Lazarus notes key panel members who are non-physicians and the likely presence of patient representatives as well. Louise Campbell reminds us that primary care physicians at the inaugural conference last year noted the importance of nursing. She adds that as she listened about the focus of multi-comorbidity at this year's conference, she hoped attendees would bring these issues back to their nurses. As she notes, there aren't really any nurses prepared to treat NAFLD. Hepatology nurses are accustomed to treating end-stage disease, not preventing earlier-stage disease, and other specialties just don't deal with it. She notes that since no nursing areas have this strain, she hopes healthcare can develop these programs and upskill nurses fairly easily based on the concepts in this conference. Jörn points out that the idea of nurse as first point of entry for patients was a key take-home from last year's discussions, and he anticipates a nursing role or discussion on issues of patient organization. From there, we shift. I note my interest in Alina Allen's talk on AI and diagnosis and Zober Younoussi's talk on payers as particularly exciting items in the Day 2 agenda, and then ask what kinds of discussions the co-hosts anticipate. Jeff Lazarus anticipates that the conversations will be, as he says, a bit disruptive, and they will focus less on methodology and more on practical impact. He notes that shorter talks should lead to longer conversations and allow every specialty to take a broader view of their responsibilities in diagnosing and treating liver disease. Jörn Schattenberg describes a similar vision by focusing on a behavioral impact discussion and how each specialty in that discussion can learn from the other. The inaugural INCBCN conference was a truly innovative meeting concept that produced fantastic discussions, lessons, and insights. These conversations can tell you what to anticipate this year, so just sit back, listen, enjoy, learn, and when you're done, join the dialogue on our LinkedIn discussion group. One question. I mean, you've mentioned patient organizations, Jeff, but where those folks are going to show up in this program or the role of nursing, where will you be filling in blanks with folks who are non-physicians, or where are there thoughts that they might come into the conversation?
Jeff McIntyre.
Yeah, so, some of that debate, Dr. Shira Zelber-Sagi is a clinical dietitian, and Harriet Rumgay, is an epidemiologist. And then we have the roundtable that will bring in patients. So, it's a small meeting with a limited program, but we definitely want all of those fields and patient groups represented as well. And patient groups, not just from the liver field. So we have reached out to the World Obesity Federation and diabetes organizations. And that's also where the meeting will be heading. So if we're a little more on endocrinology this year, we may grow that depending on the feedback, or we may then decide we want to grow with the nursing aspect.
Louise Campbell.
Just to comment on that, I think, yes, I was on a panel last year and nursing and that area and the strength of that interaction to patients was brought up several times by primary care physicians. One of the things that I get from listening to you both here now is this bringing in of multi-comorbidity fields. Now, I would hope that those thought leaders in those fields are going to take back to their nursing colleagues and other allied health as to how we can foster a strength, because although we talk about hepatology nurses, there is no skill set in hepatology nurses for NAFLD. We had to build it within hepatitis C. We, in hepatology, see patients at end-stage disease when they're diagnosed. We're not at the forefront. You did a beautiful piece a few years ago back on the equity in the fact that nobody coming into hospital really gets access to healthcare professionals that know about liver disease. So they're stigmatized from the minute they come into a hospital. We don't have that skill set within a hepatology nursing area that I'm aware of. We don't really have it in cardiology and diabetes nursing, but it's a strength we can develop quite quickly because we talk about a lot of the common areas. The program as it's been designed to me offers that ability for people to take back, share with their nursing colleagues, look at small projects that can do that, and we can upskill very quickly because we will have the first medications out in the next 14 months, we presume, with resmetirom. So I think there's some strengths within that to be able to be shared with allied health, even if they're not buried in that program as yet. Would that be right?
Jörn Schattenberg.
Yeah, I think we have room for some involvement in the discussion around the primary cares and general physicians, as you said, to include nursing as their central, the first patient they talk to in a general practitioner's practice is not the physician, but the nurse. And I think that was one of the take-homes of last year's workshop we had. While this could be the primary contact, it's again, maybe not where the primary attention is with nurses, as I understand you at this time. And for sure, this is something we want to develop. By putting the program up it is now, you can see that we've shifted a little bit to have the physicians sensitized to them, because I think through the physicians we'll also reach the nursing teams to some extent.
That's the strength of the program that you've put together. I think that was exactly my comment, is that I think they can take back, see potential opportunities to work with and strengthen their nursing field. And that for me is exciting about the way the program's been developed.
Interesting. So I guess what I'm wondering as I'm looking at the second, first of all, I think you're on your comment about having an amazing faculty throughout the meetings, I think correct, but day two, this is everybody's fantastic and fantastic on topics. I will be really interested to see what Alina has to say about automation and AI, given that at Mayo they're doing work and that she's publishing that looks past even traditional liver tests at all kinds of other measures. Obviously, we did an episode here a couple of months ago with Predictive Health Intelligence, Tim Jobson from the UK. Similar kind of thing. I do believe it will be interesting to see what she has to say and how quickly we can start to amp up diagnosis by either giving people simpler ways to do this or giving systems similar ways to gauge it. So I think that'll be fascinating. And I think that, Zobair is obviously a fantastic choice to talk about payers. What do you see happening in the discussions second day, besides the general people will converge? Any specific areas where you think things will pop up or might pop up?
I find it hard to anticipate the discussion other than say that it's going to be a very informed discussion, but also from a multidisciplinary perspective. So I would expect it to be a bit disruptive at times and asking questions maybe less related to the methodology and more about to why are you doing this at all? How does it really work? If it's as effective as you say, how can we transfer this to other settings? So I think every talk that we've lined up is going to generate a lot of discussion. That was the hallmark of the meeting last year where you were in attendance. There was a lot of discussion. We're trying to have shorter talks, but to really lay the groundwork for these discussions. And it's a chance for people who don't know as much about our field or each other's fields, but we're all related to liver health. I'm sorry, if you're an endocrinologist and you're not dealing with the liver, it's just because you're not, doing all of your job. And if you're working as a hepatologist and you're not talking about diabetes ever, you're also not doing all of your job. So it's a chance to have everyone in the room in a let's say, a friendly, supportive environment, sharing their experiences and looking at how we can push the field forward. The talks are driven by scientific excellence, but it's not to, hammer someone on their methodology. We've invited people who have proven again and again that they're leaders in the field. So now we want to hear what they think we need to know to inform that discussion.
So in the what, now what, so what design that people talk about for presentations, Jeff, do you envision the roundtables being the so what or the now what or both?
I think it's more of a now what. I think the so what was put to rest in those major or keynote discussions where we're fed and we're presented the excellence on a particular topic. That's the so what. This is what's in the pipeline. This is what's working. This is what's not working. And then a roundtable says, well, now what? We were told we need to improve risk stratification. We were told that certain aspects of AI can facilitate our work. Now what?
Okay, good. I love that. And I agree. I think last year was extremely strong on now what. Actually, about as strong a meeting as I've ever seen on that subject. So I thought that was great. Jörn, you look like you have something to add, but I'm not sure.
I agree with Jeff. If this was a mainstream liver NASH meeting, it would be all about drugs, MOAs, and a basic science lecture on how new drugs are going to be developed. But this is really about how we're going to take the development that has been made and bring it to the patient and empower the physicians taking care of those patients today to use it. There is a talk on behavioral interventions. Ono Hollebom is an endocrinologist dealing with type 2 diabetes every day. And what can we learn from that group of physicians to, we as hepatologists change the behavior of our patients? A lot of times in the discussions, we throw up our hands, say, no, lifestyle's not working anyways. Let's just move on to the talk given by Stephen Harrison and hear what the drug arena is going to look like. But this is not how this is going to work here. I think we really want to learn from each other, and not hepatology telling everybody what we think has to be done, but really also being educated on what endocrinologists have been good at, managing comorbidities in patients living with type 2 diabetes, and the increasing evidence there is generated on the role of type 2 diabetes and the risk for liver disease in these patients. A lot of physicians have not considered that. We're talking about it every day, but I think this is something we want to put out there and discuss together. I think I said that once or twice now on this podcast from a different perspective, but that's really what it's all about.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. Next week, we may post our episode on Thursday to accommodate Jörn Schattenberg's schedule, returning from 2 major events in California in the presence of a strike in Germany. We've not locked down the topic yet, but the 2 we are considering are both quite important. Until then, stay safe, surf on. See you next week on the podcast. Bye-bye now.